Good morning and welcome to Optimizing Women's Health Through Physical Therapy, but actually today we will have a bonus session because we will be taking a multidisciplinary approach to optimization of women's health through the looking glass of physical therapy, nursing, and medicine. I'd like to introduce myself. My name is Eleni Moulis. I am the physical therapist for the Young Adult Cystic Fibrosis Unit and Pediatric Pelvic Floor Clinic at Boston Children's Hospital. And at this time, I would like to introduce my co-chair, Kathy Villagomez. Kathy is the program coordinator and respiratory therapist at the Adult CF Center of Central Texas. Kathy.
Thank you, Eleni, and again, thank you guys for coming so early in the morning to join us in this great little presentation that we have put up for you. That is a little bit about Eleni. I believe it is also on the NACFC website /app. For disclosures, Eleni does not have any disclosures, but I am a speaker for Chiesi USA. Our speakers today are going to be Christina Richter. She is one of the registered nurses at the Adult CF Center in Central Texas. Michaela Green is going to go second. She's the physical therapist at the Adult CF Center of Central Texas. And then lastly, Dr. Tracy Kaczmarski, the assistant professor of pediatrics at Converge University of Pittsburgh. The description for today is here. I won't read it word for word for you guys. But like she said, basically we're going to take multidisciplinary approach to going over optimizing women's health through PT. The objectives are again listed here. Hopefully at the end of the session we will be able or have covered all of these objectives.
This time, I would like to introduce our first speaker. Christina Richter is a nurse at the Adult CF Center of Central Texas. And Christina enjoys participating in quality improvement projects within the clinic, specifically related to women's health and pregnancy. Christina.
Stop one.
Good morning. 7:30 on a Saturday. Woof. Okay. Like Eleni said, I'm Christina. I'm one of the nurses at the Adult CF Center in Central Texas in Austin. I'm going to go over a pretty brief background and overview. We're going to talk about anatomy a little bit. We'll talk about Trikafta, how it relates to pregnancy, and why we're here. Let's see. I'm not technically advanced. I have no disclosures related to this presentation. Like we said, we're going to talk about pelvic floor anatomy, diagnostics, treatment of pelvic floor disorders, highly effective modulator overview, highly effective modulator therapy effect on pregnancy, and then some pregnancy considerations. Okay, so let's start with the pelvic floor. So what exactly is the pelvic floor? The pelvic floor muscles form the base of the group of muscles known as your core. Your core muscles include your pelvic floor muscles, abdominal muscles, back muscles, and diaphragm. Together, these muscles attach to your pelvis and spine, creating stability throughout your body's center. The two main muscles are the levator ani and the coccygeus. Here are a few different views of the anatomy. The first picture you can see shows a cross-section of the bladder, and the second shows the side view with all the pelvic organs. So normal function of the pelvic floor, when you're breathing and your pelvic floor is functioning normally, your diaphragm and pelvic floor work together, kind of like a piston. As this graphic you can see, it shows on the left a piston. When you inhale, your diaphragm moves downward into your abdomen. This then causes increased pressure in your abdomen, which results in the pelvic floor lowering down. Then when you exhale, your diaphragm rises into the lower rib cage. The pressure in your abdomen decreases and the pelvic floor moves up. So pelvic floor disorder risk factors, they include injury or trauma, including childbirth or surgery, overuse due to heavy lifting, chronic coughing or constipation, hormonal changes, including lack of estrogen during menopause, which thins the support structures and tissues that hold the pelvic organs in place, insulin use, diabetes. The cause is unclear, but it's likely caused due to damage to the urethral sphincter due to microvascular compromise, obesity, and natural aging process. So the four most common pelvic floor disorders include urinary incontinence, which we are going to go over today, as well as fecal incontinence, anal incontinence, and pelvic organ prolapse. So the two main types of urinary incontinence are stress incontinence and urgency incontinence. This graphic shows what happens during urgency incontinence, which you can see the bladder contracting before, and that's in that middle picture. And then finally in stress incontinence, which is that last picture, the urethra is too weak to stay closed. So stress incontinence is caused when there is increased intra-abdominal pressure, commonly caused by laughing, coughing, or sneezing. As the previous slide showed, the urethra is unable to stay closed and allows the urine to leak outward. This is the most common type of urinary incontinence, affecting 1 in 3 women and 1 in 4 women with CF. There are two main types: urethral hypermobility and intrinsic sphincteric deficiency. Here in these slides are just some more visual representations, but in the first image you can see normal function during increased abdominal pressure with that yellow arrow going downward, and then in the second slide you can see the urine flowing outward because of the loss of urethral support. Urge incontinence is the second type we're going to talk about, and the most common symptom of this is the sudden urge to urinate followed by involuntary loss of urine. This is also referred to as overactive bladder or OAB. So diagnosing urinary incontinence, first a pelvic floor or pelvic exam will be completed, including lab work to rule out other sources of incontinence like infection. There may be a bladder scan performed to rule out stones or structural problems. And then the most accurate way to diagnose urinary incontinence is going to be with multi-channel urodynamic testing. And so briefly, urodynamic testing is a set of tests used to measure lower urinary tract function. Information is gathered during all the different stages of urination. Another test that's commonly performed, usually during urodynamics, is the Q-tip test. This measures urethral hypermobility, and so as you can see in that picture, the Q-tip, a woman's asked to bear down, and the Q-tip should not pass 30 degrees, and if it goes past 30 degrees, that's usually an indication for surgery. So moving on to medications and treatments, our first is going to be anticholinergics, which calm the overactive bladder. These include ditropan, Vesicare, and Detrol. Alpha blockers, which are used only in men as they work on the muscle fibers in the prostate, relaxing them and making it easier for them to void. Myrbetriq is used for urge incontinence, and it relaxes the bladder muscles and also allows the bladder to fill fuller. And then topical estrogen, which is used for menopausal women. This actually tones and rejuvenates the tissues in the urethral and vaginal areas. And it's important to know that this is not contraindicated in women who cannot receive estrogen therapy, such as women who have a history of breast cancer, as it's not systemic. There's also devices that you can use to treat. So the first type is vaginal inserts. As you can see in the first picture, You can see the cross-section of the little device there, and then the second picture is actually the device itself. These are kind of nice because they're over the counter and you can get them without a prescription. Next type we're going to talk about is the urethral insert. This is just a small device that's inserted into the urethra before physical activity. It's basically a plug, and then before the patient urinates, they'll remove the plug. Excuse me. The last type is a pessary. This is a silicone ring that's inserted into the vagina, and in addition to providing compression to the urethra, as you can see from that first picture, it also supports the dropped pelvic organs, if that's a problem as well. The second picture is just a bunch of different kinds. Other treatments include electrical stimulation, like sacral nerve stimulators or Botox injections. And lastly, and probably most importantly today, is pelvic floor therapy. It's a treatment of all the pelvic floor disorders, and the goal of pelvic floor therapy is to stabilize and strengthen the entire pelvic floor, including the core. Women with CF, however, historically have tight pelvic floor muscles, and so their therapy will probably focus more on relaxing and retraining those muscles to learn how to relax so they can successfully urinate. Michaela's going to go into that significantly in the next section. Ooh, got ahead of myself. Nope, just kidding. Education is major for these patients. It should include focusing on decreasing the risk factors. It's really important for us to focus on this for our CF community because with Trikafta and all these medications that are prolonging life and making really their quality of life better, we don't want them suffering with pelvic floor issues or incontinence that would dramatically reduce their quality of life. Some more little considerations: avoiding bladder irritants, caffeine, carbonation, citrus cocktails, that's the 4 C's. Diuretics, sedatives, opiates, and certain vitamin supplements will also cause bladder irritation. Additionally, with patient education, it's really important to create a feeling of security in the environment. Ways to do this is commending your patients on their bravery for being willing to even talk to you about this. Avoid phrases like, oh, don't be embarrassed, because that just makes them feel like they should be embarrassed, which could cause, more distress for them. Acknowledge how difficult discussing it is. Just make them feel comfortable. When discussing symptoms with your patients, just focus on fact-finding questions. For women, the average wait time between symptom development and receiving an actual diagnosis and treatment is 6 years. So unfortunately, it's not talked about very much. And so I think it's really important, especially for us as caregivers, that we have a level of comfort discussing these things with our patients so that they can discuss it with us. All right, so now we're going to transition on to pregnancy and CF, which is my favorite. So what's changed? With the introduction of highly effective modulators, pregnancy has steadily increased, with the largest jump being after the introduction of Trikafta. I'm going to show a little video that just kind of shows the pharmacokinetics and how Trikafta works. So I'll play that hopefully right now. Oh, nope. Oh, no.
Okay.
It's such a good video, too. Let's see. Sorry.
Time.
I can't get it to go. Sad.
What is that saying?
It's saying the browser's out of date.
Hit Google Chrome and see if that does anything.
Sacrum. Oh, right there. Man, I sure built that video up for.
That's okay. We'll get it. Don't worry.
Let's see if I can find it. If I don't show it over there, it goes.
Did you save it in your history?
This isn't my computer.
That's okay. You can just move on if you can't do it.
Okay. Man, I really wanted y'all to see this. Okay, anyways, basically what it shows is how CFTR functions and how Trikafta comes in and kind of saves the day. Specifically, it's talking about in the lungs. So in addition to CFTR being located in the epithelium of the lungs, it's also found in the reproductive tract, among other places in the body. But there's a high concentration of CFTR found in the cervix, a moderate amount found in fallopian tubes in the uterus, and little to none found in the ovaries. The exact effect of CFTR modulators is not completely understood yet, but obviously we're definitely working on that. Let's see. So the number of pregnancies in women with CF, so as you can see, this starts in 1999, and there was 137 reported pregnancies. And then you can see in 2004, and steadily increasing. That star right there by the 310, remember that number 310, because that was right before Trikafta was approved, and it went from 310 to 619 in 1 year. It's really important to know too that these are reported pregnancies. So in these reported pregnancies, 25 to 50% of those were unplanned. So education here, again, is so important, educating our patients about the increased fertility and starting young pediatric patients. So what happens in the body now that these ladies are pregnant? So overstretching and weakening of the pelvic floor as pregnancy increases or progresses rather, continued and potentially worsened cough as ability to perform effective airway clearance is lessened, amount of space is decreased as the fetus grows. Constipation is common in pregnant women in general, and in addition to pelvic floor disorders, the risk of diastasis recti affecting the abdominal muscles is also a concern. This is just a slide to show the pelvic floor muscles in a not pregnant woman, and then as you can see in the second slide, pelvic floor muscles stretched around the fetus and all distorted. So you can see the absolute stretching that goes on during pregnancy. One of the ways that we can support our pregnant women is to help them to establish a safe exercise routine. Exercise in pregnancy not only contributes to a healthier outcome, but it encourages airway clearance, which, as we talked about earlier, it becomes increasingly difficult as the pregnancy progresses. Michaela's going to go into much further detail about this in her presentation, but just wanted to touch on that. Postpartum considerations include ensuring that women receive enough nutrition. So if women choose to breastfeed, women without CF need an additional 330 to 400 calories to sustain their nutrition and be able to produce that breast milk. Women with CF need an additional 500 to 600 calories. Also encouraging our new moms to rest, recover, don't push themselves. Their body just went through quite the ringer, and it's really important to get that clearance from their OB before they start any sort of exercise program. And then just not really related to PT or anything else, but being familiar with postpartum depression signs. So women are screened pretty routinely for postpartum depression, but if you can familiarize yourself with those signs, you might be able to save a life or two. They include things like difficulty bonding with the baby, severe mood swings, depression, or even thoughts of harming themselves or the baby. And that is all I have. Thank you so very much for letting me speak to y'all today at 7:30. Take care.
She just ran off like she don't want to be up here anymore. Did you want to do questions at the end, or do you want to do save all questions to the end?
We'll save all questions to the end, but please, we have the app working, so if you'd like to send us your questions through the app, we'll be happy to address them at the end.
All right, so our next speaker will be Michaela Green, again, a physical therapist. You can come on up, girlie. Physical therapist for the Adult CF Center of Central Texas.
Thank you. I am going to be talking about optimizing women's health through physical therapy. I don't have any relationships to disclose, although I do feel like I have to disclose I'm not a formally trained pelvic floor physical therapist, but I relied on Eleni. She is formally trained, and also my counterpart, Jenny, in the pediatric side. So here are our objectives that Kathy already went over. So, according to the APTA, physical therapists work with women of all ages and abilities to help people stay moving, and regular physical activity can benefit your physical, mental, and social health. It can also help prevent or improve many chronic conditions, such as heart disease, diabetes, obesity, depression, and some forms of cancer. Women are not always comfortable speaking about pelvic floor and incontinence, and so the more comfortable we become speaking about it, the more comfortable our patients will be. And like they always say, leaking is not normal. It's very common for women to have urinary incontinence, but it's not normal. And so the more comfortable we are talking about it, the better it can be. PT can help treat areas to improve overall quality of life, specifically with incontinence, constipation, pelvic pain, pain during sex, and lymphedema. And then looking at pregnancy, physical therapists can help assist in treatment plans to reduce pain, as well as muscle, bone, and joint problems if they're experienced. And we can help develop or adjust a personalized exercise program to keep those women active during pregnancy. Physical therapists, we're movement experts, and so we can improve quality of life through hands-on care, patient education, and prescribed movement. So that movement, all adults, according to the American College of Sports Medicine, should exercise at least 150 minutes of moderate intensity exercise. That's for all individuals, not just individuals with CF. And then they recommend 2 times per week doing muscle strengthening activities, so working all major muscle groups within that. So then specifically, looking at my role in the CF clinic, I help develop individualized fitness programs, help with endurance testing annually, educate on pacing and heart rate recommendations to get that moderate intensity exercise. Everybody remembers 220 minus your age times 60 to 80% of that. And then addressing posture, strength, and endurance, educating on injury prevention, and then also looking at bone density and educating on the progression of osteopenia, osteoporosis, reinforce active airway clearance, and then of course screening for stress urinary incontinence. So always asking, how often are you leaking, or do you have experience with leaking? And I'll talk a little bit about that. So specifically, a lifespan of overlapping challenges for women with cystic fibrosis. I'm an adult physical therapist, so I'll focus more on the adolescents and adults, but in adolescents, looking at the timing and effect of puberty, and it's often a delayed puberty, looking at the impact of sex hormones and the changes on their body, and then body image issues as they grow and adjust. Looking at the reproductive years, conversations about fertility. Our fertility has increased post-modulators, so having those conversations and education is key. The effect of contraception on health, looking at pregnancy and the appropriate medications and airway clearance during that pregnancy time. Implications of parenthood, once they have the children, looking at time management with caring for an individual while having such a huge treatment regimen themselves. And then looking at menopause as their body changes and ages, looking at urinary incontinence, osteoporosis, osteopenia, and then lack of information on this aging population, which is an exciting time. And Tracy will speak a little bit more about what the future looks like. So, pelvic floor physical therapy. Some medical diagnoses that increase your intra-abdominal pressure, which can lead to pelvic floor disorders, are cystic fibrosis, COPD, smoking, allergies, obesity, and constipation. So anything where you increase that intra-abdominal pressure can put pressure on the pelvic floor and cause to leaking. So part of the physical therapy evaluation will be a thorough exam. The goal is to identify the cause of urinary incontinence, constipation, or pelvic pain. asking your patients to describe your symptoms and daily experience, and then doing assessment of your muscles, of your pelvic floor, your hips, and your lower back, because everything is connected. And then looking at coordination, strength, and flexibility of those muscles, and really addressing the cause of the pain. So the assessment of the joint and muscle tightness, you want to know if the muscle's tight or weak, and look to see if there's any nerve involvement as well. So screening of your pelvic girdle, looking at soft tissue assessment, doing a visual assessment or visual exam of the tissues, sensation testing, and then looking at internal assessment of the pelvic floor muscles. During the evaluation, you'll also use questionnaires and a bladder diary. And in that bladder diary, you really want to know how many leakage episodes do you have per day, the number and types of pads that you're using or special briefs that you're using, looking at your frequency of urination throughout the day, and then looking at activities that cause leakage like jumping, coughing, sneezing. And then you'll also want to keep track of your fluid intake, because some women decrease their fluid intake because they're afraid of leaking throughout the day. And then looking at urine output per void, and then looking at urine output for the 24 hours as well. And then, like Christine talked about, talking about bladder irritants to avoid. So part of that assessment, you're looking at are muscles tight or weak. Physical therapy can create a treatment program to improve specific pelvic floor muscle function, and that way you can help gain control over your symptoms. You can reduce the need for pads and special underwear and medications, and possibly avoid future surgery. So physical therapists can help people with pelvic pain restore strength, flexibility, and function to those muscles and joints in the pelvic region. And then that can really help with quality of life and improve quality of life. So where do we start with pelvic floor with this patient population? Individuals with CF tend to be abdominal dominant. So their respiratory and abdominal muscles respond quicker during the respiratory cycle. Patients with CF have shown to have tonic abs at rest when they're in supine. Even when they don't have any load, those muscles are higher tone. They have higher level of ab recruitment than healthy controls because they've been coughing their entire life. And so that coughing, that tension, increases that intra-abdominal pressure. And their abs actually turn on sooner during that respiratory cycle. So individuals with CF tend to have tight abdominal muscles, and that leads to tight pelvic floor muscles. Many patients need to master relaxation before progressing to strengthening. And it's a red flag if your pelvic PT only prescribes Kegels. Because if you do a Kegel on a tight muscle, you're not doing anything to strengthen that pelvic floor. Forgive my demonstration of my hand with my pelvic floor. I talk with my hands a lot. So yes, a chronically tightened pelvic floor is overactive. And so you can actually utilize your diaphragm to do deep breathing to help relax the pelvic floor. And you always want to lengthen before you strengthen. And so if I have my tight pelvic floor and I go to strengthen it, I don't have very much room to strengthen. And so if you work to lengthen the pelvic floor, you can actually strengthen through that full range of motion. I'm going to use my elbow instead. If you have a tight elbow, like after a fracture, you have tight biceps, you're going to want to stretch into that full range of motion, and then work on strengthening in that full range of motion. The same works for your pelvic floor. So lengthen before you strengthen is a huge thing with this patient population. So how do we lengthen the pelvic floor? You want to coordinate it with your diaphragm. And so your diaphragm and your pelvic floor actually mirror each other. And I'm going to come to the side. Oh, actually you can't. I'll go up here. Your diaphragm is at a U shape at rest. And so when the diaphragm engages, it's going to push down, moving your guts down and allowing space in your lungs to expand. And what that does is they mirror each other. So as your diaphragm contracts, your pelvic floor goes down. That's the same thing here. So when you breathe in, your lungs fill with air and your pelvic floor is pushed down. And when you breathe out and you exhale, everything naturally rises back to the position. And I like to imagine it as a barrel. So your core muscles are the front of the barrel, and those 4 layers of your core muscles. And then your back is the back of the barrel, and then your diaphragm's the top, and your pelvic floor is the bottom. So it all moves together. So the first step is coordinating your pelvic floor relaxation with your breathing and utilizing your diaphragm. So we are actually going to do some diaphragmatic breathing. So if you want to get in a comfortable position, this is the active part. Placing one hand on your abdomen, one hand on your chest. We're going to take a deep breath in, and on the inhale, I want your hand to come away from your belly as your belly expands. So deep breath in. Good, and on the exhale, that hand should come back towards your spine. We're going to do it 2 more times. Inhale. Good, and exhale. Good. One big inhale. Using that diaphragm, pushing that hand out, and exhale. Good, good. If you notice a lot of movement in your upper hand, that means you're using more of your accessory muscles in your upper chest to breathe. And so that's a cue for my patients. I just tell them I really want the bottom hand to be moving to really utilize their diaphragm. This is difficult for some patients, especially if they've been coughing for a long time. It's hard for them to coordinate that diaphragm and retrain that muscle. We're going to try another round of breathing, but on this time, on the exhale, I want you to think about doing a pelvic floor contraction of lifting and tightening your pelvic floor and maintaining it for that exhale. So I'm going to put both hands on my lower belly because it helps just a little bit. So we're going to inhale. Good, and tighten and lift that pelvic floor and breathe out.
It's a squeezing motion.
Good. Breathe in. Good. Tighten and lift. And exhale. Good. Forgot the cue. Relax everything in between. Good. And breathe in. Tighten and lift. And then exhale. Good. So it's kind of difficult to engage that muscle, specifically while you're doing your breathing. And so you want to work this technique of using and utilizing that deep breath to relax the pelvic floor. And sometimes that squeezing and lifting can help your brain think like, oh, I am tightening everything down there, and then you can relax after. So eventually you want to progress the length of time which you can hold that pelvic floor contraction once you've worked on the relaxation part. And then you can work the contraction of the pelvic floor. Once you've relaxed, you can do that relaxing diaphragmatic breathing in different positions. If you start in supine, it's gravity eliminated, and so you don't have to really work against gravity. It might be a little easier for the patients to engage that diaphragm. But then you want to work that pelvic floor contraction in a series of progressions and do it more functional training. A consistent pelvic exercise program, it's 8 to 12 weeks to really hypertrophy those muscles and add muscle fibers to your pelvic floor. And it must include a progression of quick flicks and sustained endurance contractions. So doing your diaphragmatic breathing, it's great to do it sitting, but also doing it in different positions. Different yoga positions for diaphragmatic breathing, child's pose, happy baby, yogi squat, and sphinx pose, just to really help them relax their pelvic floor in multiple different positions. Because how many times a day do you think about your pelvic floor and relaxing your pelvic floor? For me, it's 0. So really helping your patients realize that they have a tight pelvic floor and those muscles can relax. It's like with your shoulders. How many times a day do you think, I need to relax my shoulders? It's the same thing. So the strengthening exercise, you always want to start lengthen before you strengthen. I'm just going to say that again because these patients tend to have tight pelvic floors. So utilizing your diaphragmatic breathing first, and once they've mastered relaxation techniques, then going to strengthening. You want to start in supine because it's gravity eliminated. You can start with holding your isometric pelvic floor contraction and utilizing a knee squeeze. So if they're in hook lying position with their knees up, you can put a towel between their knees and work on squeezing their adductor muscles to really help support their pelvic floor. You can do more dynamic positions in the supine position of doing a pelvic floor contraction with a bridge. That can be helpful. And then the next progression is seated. Performing pelvic contractions and sitting actually just allows the contraction against gravity. And then you can kind of do a similar thing with a towel between the knees, squeezing and engaging other muscles around the pelvic floor to help support the pelvic floor. And then progress to standing. A big one to do is a pelvic floor contraction and then move from sitting to standing, because a lot of women leak actually when they go from sitting to standing because those muscles aren't engaging in the correct order. And then doing more of the advanced standing and more dynamic movements. I like to start with walking before you go to hopping, but eventually just retraining that pelvic floor to engage and strengthen during dynamic movements. Oh, that picture is over my words, but that's okay. Another part of training is the core muscles, and starting with your TA muscle. Your transverse abdominis is the deepest of the core abdominal muscles, and it supports your internal organs, kind of like a corset, like in that picture. And so being able to engage your TA is key for core strengthening. If you think back to the diaphragm and the pelvic floor muscles, that's the front layer of the front of your cylinder in your core. So you can start, we kind of learned how to strengthen our TA with low back pain, starting in hook lying, engaging your TA, and then doing some marching in place. At least that's where we started in PT school. And then progressing to like a plank or a side plank are good for your core muscles. And because I am not a formally trained pelvic floor therapist, just some other treatment for pelvic floor are biofeedback. So looking at internal sensors to read and measure your pelvic floor muscle activity. And it gives you a visualization of when your muscles are turning on. So it can be a visual cue for your patient to engage your pelvic floor muscles or even help relax them. Looking at electrical stimulation as well to increase muscle function and activation. Looking at ultrasound to assess isolated contractions of the pelvic floor and abdominal wall to improve the coordination of all of your muscles. Part of the education also is talking about how often you go to the restroom and doing kind of talking about poop and pee and pain during sex is huge. And educating on emptying your bladder every time you urinate and not forcing those muscles and using those muscles to contract to have a initiation. And then the same with constipation or defecation, like you should never bear down. It should never be a forceful contraction. So things like squatty potties can help with those to just realign and help relax the pelvic floor. And reducing the risk or reducing the education of, they call it in Bluey, if you are a fan of Bluey, a tactical wee, the just in case pee, really educating your patients that that is not a good form to help with your bladder. It's not a good way to support your pelvic floor. Okay. So another area of women's health that physical therapy can play a huge role in educating is during pregnancy. Like Christina talked about, in 2019, we had 309 reported pregnancies through the registry, and in 2020, we had 619. So education is huge in this with this patient population. It's super hopeful, but also a lot of those pregnancies were unplanned. So education should start early and often. And that's actually why I'm here today, is Christina created a wonderful education for our patients, for their OBGYNs, to know how to care for patients with cystic fibrosis as their pregnancy progresses. And I created an exercise program for our patients as a part of that education. So with any exercise program, you always want to be cleared medically. So we encourage our patients to speak to your OBGYN before starting a new exercise or activity program while you're pregnant. And then follow-up care, routine prenatal care is often sufficient to monitor and progress an exercise program. So physical activity and exercise are actually very important during pregnancy for both mom and baby. It doesn't matter if you're a marathon runner or you walk for 10 minutes 3 times a day, you're still getting the benefit of exercise. And it's perfectly safe as long as you're cleared from your OBGYN to start a new workout. So the benefits of exercise, You're going to have improved circulation. Pregnancy is a hypercoagulable state. The woman is in a hypercoagulable state, which means the body is increasing the amount of blood in the body to support the baby. Their body is more prone to blood clot formation in pregnancy due to high levels of estrogen, increased levels of antithrombotic factors, or your clotting factors, and decreased physical activity. So as your pregnancy progresses, the uterus is growing, and so it might start compressing on blood vessels in the pelvic area, and so that's called venous stasis. And so walking and exercise can really help circulate the blood from your lower body back up to your heart. Another benefit of exercise is reducing the risk for gestational diabetes and hypertension during pregnancy, improve muscle and cardiovascular strength, especially if you're using your lower body, stronger muscles that require more blood flow. That helps with circulation. Exercise can help decrease the incidence of urinary incontinence, both during pregnancy and postpartum. And exercise can help reduce cortisol levels, improve moods, and reduce symptoms of postpartum depression. Doesn't solve it, but it helps manage the symptoms. As well as exercise can help improve body image, which is a huge thing with individuals with CF that they've had to deal with their whole life, and now their body changes dramatically. So we're going to talk a little bit about the space and anatomical changes. Christina mentioned as the baby grows, everything is kind of smushed out and down and around. So it's limited real estate as you progress through the trimesters. And so breathing can become labored with a small human pushing on your organs. So mobility training is huge for the thoracic rib cage, looking at thoracic extension and mobility, and then also strengthening shoulders, because our patients tend to be in this position. So really training and strengthening, stretching anterior muscles, strengthening posterior muscles. Looking at the joints, a hormone relaxin is released to help soften the ligaments and prepare the mom for delivery. And then looking at your balance, your center of gravity is shifting forward as your increased weight of your stomach and breast tissue causes your center of mass to shift forward. And what that causes can be, as everything shifts forward, your lower back and your SI is carrying just a little bit more weight than normal, and so you might have some back pain or SI pain. So looking at postural exercises, the diaphragm on the left is in that U shape. It's supposed to sit on top of that baby, and so think about how much less movement the diaphragm has as a pregnancy progresses. So really working on postural exercises and mobility of the chest wall, spine, and shoulders is huge and very important. Respiratory muscle training should be increased as the diaphragm is often pushed up, and utilizing the diaphragm is often difficult. Looking at costal excursion and use of your intercostal muscles can be difficult as there's less space. I like to encourage thoracic extension with a little bit of mobility. So I have patients with their elbows on a table, just kind of getting into extension, and then the weight of the baby can help stretch and use gravity into that extension. Anything to keep them moving, really. So exercise recommendations. The American College of Obstetricians and Gynecologists recommend that women should do at least 150 minutes of moderate intensity aerobic activity during pregnancy and postpartum, which that is the same number for all adults. So nothing really changes. Exercise is super important during pregnancy. And even if it's spread out, 10 minutes in the morning, 10 minutes in the afternoon is still about 20 minutes a day, and 20 minutes a day is 150 minutes per week. So it's important to keep your patients moving. So how will pregnancy affect their workout? During the first trimester, you won't have to adjust too much as the uterus is still very small. My patients tend to report a little bit more fatigue in the morning, and so they have to adjust their workout time. During the second trimester, they might have to, the fatigue only increases as the pregnancy progresses, and so they might not be able to do as much. So adjusting the intensity and then listening to their bodies. And then the third trimester, might have to reduce that intensity just a little bit. Always listening to the body and avoiding exhaustion, persistent elevated heart rate, overheating, and dehydration. In the past, the research suggested that your heart rate doesn't go over 120 or 130, but current research suggests that is not the case anymore. So using that same recommended heart rate, 220 minus their age, and getting to 60 to 80% of that is what the research says right now. So ways that you can adjust and modify your exercise: you can decrease the amount of weight that you're using for resistance training. They can perform repetitions in a slower manner, doing more eccentric work than concentric work. Increasing the number of repetitions and decreasing the weight is helpful as well. So in general, you should be able to, I use the talk test, you should be able to carry on a conversation while you're exercising. If you can't speak normally when you're working out, you should probably decrease your intensity. I use the RPE scale, 1 to 10, 1 light activity, 10 being I can't catch my breath. I normally say 6 to 7 is a really good place to be while you're exercising. I love this picture because she is she's intense. I love it. And she's probably in that 3rd trimester as well, and still going after it in her workout. So exercise recommendations for low impact activities: swimming, walking, biking; moderate impact activities, weightlifting, jogging; and then that high impact activities: running, high intensity interval training. They did say the things to avoid are contact sports. So ice hockey, soccer, basketball, gymnastics, horseback riding, downhill skiing, things that can be traumatic or high risk of falling. Thought that was pretty funny. But if my patients do not exercise and they want to start, I always have them start with a walking program. I start with 10 minutes, and if they can do 10 minutes, can they do 10 minutes twice a day, and then increase by 5 minutes at a time. Always listen to your body. I have reminders to stay hydrated. That's why I picked this picture, because she's got water. Staying hydrated. I live in Texas, so it can get very hot. So we educate our patients on making sure they're rehydrating with electrolytes, rehydrating with salt, and making sure that they stay hydrated as they're walking out. And then always doing deep breathing or some huff coughing after the walking, just so they can help with airway clearance and get a little more bang for their buck. I had a couple patients that wanted me to put together a resistance training program for them because they enjoyed strength training. So what I created was just a lower body, something weight bearing with their arms so they can continue to have good bone density. And then as it progresses, I did some single leg and alternating legs, because that really helps retrain the pelvic floor as well. If you do it in a unilateral stance, that pelvic floor has to work a little harder to engage. So this is the first trimester. During the second trimester, I added in diaphragmatic breathing so that those muscles continue to strengthen and work. As space becomes more limited, they can really engage. And then the third trimester. And then just a reminder, if any of the exercises cause pain, discomfort, or funny feeling, stop. Some contraindications for exercise during pregnancy. These are absolute contraindications, and these patients will have that conversation with their OBGYN prior to starting any exercise program. Most of these patients, if they have these issues, will be on some form of bed rest or light activity. And then also keeping in mind avoiding excessive heat, such as hot yoga, and then laying flat on your back or your stomach as your pregnancy progresses. Some relative contraindications for exercise. I won't read them all, but these patients will be aware of these issues, and they'll have this conversation with their OBGYN prior to seeking out a physical therapist. And then warning signs when to stop exercise when you're pregnant. If your patient has any vaginal bleeding, shortness of breath, dizziness, headache, chest pain, muscle weakness, calf pain, preterm labor, that's pretty good. You should stop exercising if you're in preterm labor. Yeah, and these are for all patients, not just individuals with CF. So another thing that our patients will have is low back pain or musculoskeletal pain. We can help with it. Sometimes an SI belt will help to relieve and help carry that weight. And then also, if it's significant enough, a referral to an outpatient physical therapist, we can help with low back pain. And then postpartum, or in your 4th trimester, most women have issues with diastasis recti, which is just the separation of your core muscles. They diagnose it with how many fingers can fit in between. It's pretty fun. A lot of women report they feel like a flabby, the mom tummy, or they feel weak, and lifting the baby can be difficult. So what I read was that most of it heals within a couple months postpartum, but retraining those pelvic floor muscles, because currently there's not a lot of postpartum pelvic floor retraining. So I think this is a huge opportunity for us as physical therapists to go into this space and help retrain, because women have massive trauma in their pelvic floor, and then some have C-sections, and then they're sent home without any education on how to recover. And so this is where I'm actually working in my hospital to create education for our patients so that they can feel confident in returning to their activities of daily living, even just learning how to lift their baby correctly to help support their healing abdominal muscles. And then looking to the future, physical therapy can give women the tools for healthy aging. It's an exciting time to be in this patient population, because we're having these conversations of what does aging look like, what does getting on and off the floor with your babies look like, or eventually your grandchildren. So educating our patients on the risk for osteopenia, osteoporosis, and really helping individuals start a resistance training program or a weight training program. I won't go too far into that because that's not the topic of this discussion, but it's something I'm very passionate about. And then looking at different forms of urinary incontinence as women age. They're not going to have just the issues with coughing, because a lot of our patients don't cough anymore, or they don't cough as frequently, only with airway clearance. And so once they have learned to relax their pelvic floor, they might have other issues of urinary incontinence as they age. So it's a really exciting time to be a physical therapist in the CF clinic, just because our conversations are changing on what was and now what can be. So yeah. And a special thanks to my center for allowing me to educate your patients and challenging me to put together an exercise handout. And Eleni for being my pelvic floor guru, and Jenny, she's the pediatric counterpart. So those are references.
Thank you, Michaela, for a wonderful PT pelvic floor presentation. At this time, I would like to introduce Dr. Tracy Kazmierski. Dr. Kazmierski is an associate professor at the University of Pittsburgh School of Medicine in the Department of Pediatrics and Division of Adolescent and Young Adult Medicine. She is a pediatric pulmonologist and health services researcher at UPMC Children's Hospital of Pittsburgh, and serves as the chair of the Institutional Task Force. Her research centers on the importance of comprehensive health care for adolescents and young adults with pediatric onset of chronic disease. As a core member of the CF Foundation Therapeutics Development Network, Sexual Health, Reproduction, and Gender Research Working Group, her current projects focus on improving the sexual and reproductive health and care of people with cystic fibrosis. Please, let's extend a warm welcome to Dr. Kazmierski.
Hi, everybody. Let me just navigate out of this, I think. All right. So thank you so much. Today I'm going to talk about urinary incontinence and CF, and I'm really going to talk about this as a 2022 update. and kind of what we know and what we used to think and where we need to go from here. So these are my disclosures. And we'll start in the past. So this is what we knew. And I think about this as before the widespread use of highly effective modulator therapy. And I'm gonna preface all this by saying we didn't know much. So in 2017, there was a systematic review that was done that really reviewed all the papers that have been published on urinary incontinence and cystic fibrosis in the past. And the prevalence was all over the place. So in those publications, it ranged anywhere from 5% of people with CF to 76. When you looked at it, it was really, the contributors in that were age and then sex. So among adult females with CF, the range in those studies was anywhere from 30% to 76%. And then among males, it was anywhere from 5 to 15%. So even though we're focused here on female reproductive health today, I think it's important to be screening for this among everybody. In all those studies, there was no clear association with disease severity. So there was nothing in those data that said, if you cough more, you're going to have more urinary incontinence. The most common triggers, I think this isn't rocket science, this is coughing, laughing, sneezing, physical activity, and then airway clearance and spirometry within clinic. Any associations with constipation, with parity, or with diabetes were not assessed routinely in these papers in the literature. Nor did they assess the impact of urinary incontinence on daily life uniformly across these studies. And this isn't commonly discussed with CF providers. Every study that looked at this, every patient basically said, we don't talk about this. Several years ago, we did a survey at 5 centers here in the US among women aged 15 to 24 around sexual and reproductive health concerns. And we asked about urinary incontinence. And in that cohort, 1 out of 6 of these adolescent and young adult women said they experienced urinary incontinence. More recently, and this was recently published in JCF, we asked women ages 25 years and older about urinary incontinence. Half of women in this age range had experienced urinary incontinence. More impressively, 30% experienced it 1 time a week or more, with 14% having daily episodes. 45% of those with UI reported that it sometimes or often inhibited completion of airway clearance. And there was no difference in those on CFTR modulators. I have to note that this was prior to the widespread uptake of highly effective modulators, and we're going to get into that right now. But these are concerning numbers, and it really shows that where we were meant that we had a long way to go to provide better care for these folks. All right, so what about now? I'm going to present some data from a pilot project out of the University of Pittsburgh that's led by my collaborator, Dr. Megan Bradley. She's a urogynecologist at UPMC, and she's been looking at urinary incontinence and CF as part of this pilot grant. And there were 2 aims to this study. And the first was to really explore what are the experiences, knowledge, caregiving, or care-seeking behaviors, and treatment preferences for urinary incontinence in the age of highly effective modulators. So we recruited females with CF and urinary incontinence over the age of 18. We partnered with CFF Community Voice to engage them in semi-structured interviews. And Megan and her team interviewed 26 participants with an average age of 45.1 years. And you can see that big range from 24 to 61 years of age. There were a couple main themes that came out, and this is the most striking one, and I think the one that I'm going to spend the most time on. Participants agreed that highly effective modulator therapy has greatly improved urinary incontinence symptoms and decreased bother, with most females with CF and urinary incontinence only reporting mild symptoms. As one participant said, it's not too bad right now. Before I started on the modulators for CF, it was really annoying. I just leaked all the time, especially every time I coughed. Another participant reflected on this a little bit more. I think it's mainly just the drastic shift after taking Trikafta, because if you had asked me, even knowing that the coughing might decrease, I think I might have assumed that the muscles were still weak and that I would still experience incontinence. I don't fully understand how it just so immediately disappeared that when the coughing went away, the incontinence went away. Because I guess I thought that I had weakness in the muscle that would be there regardless of the coughing, but that doesn't seem to be the case. My understanding of the cause of incontinence maybe was incorrect. I don't know. It just was so fascinating to me that it was clearly linked to the amount of coughing I was doing. And the more coughing I had, the more incontinence I experienced. Then the coughing went away and the incontinence went away. The second theme that came out of these interviews were most participants had previously discussed urinary incontinence symptoms with family and or peers, but had not sought care due to stigma or low priority. One participant reflected, I just feel like there's a big social stigma around incontinence, period, in my opinion. Another shared, I related to older women with it. My mom, whenever she sneezes or whenever she laughs too hard, she'll pee herself. That's something we have in common and can talk about together. No, I've not really had any conversations with anybody with CF about it. It honestly never occurred to me to discuss urine issues with my gynecologist. That might sound ridiculous. And in addition to this, many participants felt that their CF providers don't know much about urinary incontinence and certainly don't know how to treat it. So it was not something that they were going to bring up in CF clinic, even though it was something associated with CF. The third theme, females with CF and urinary incontinence had minimal knowledge about it in general and how it relates to CF. I liked before when somebody said leaking is never normal, because I think that there's this misconception that sometimes it is. This woman said it. I just kind of figured it was relatively normal. I didn't really think there was anything that could be done. Honestly, I didn't know this was a thing that could be correlated with CF until a webinar kind of thing. She went on to say, they were throwing out a ton of different statistics, and one of them had to do with this. That was my first flag that, oh, this could be a correlation. And the fourth theme is most desired broad screening for urinary incontinence from their CF team and improved multidisciplinary care. They wanted annual screening for UI symptoms in the CF clinic. If it was one of those little questions that you check mark yes or no, then that makes it very easy to open the conversation because it's a very passive way to raise your hand for it. Then it opens the door for conversation. That could be helpful. They also felt that they would need a provider outside of their CF team to have urinary incontinence addressed adequately, but also didn't want to have to explain their CF physiology to these providers. And this is really common across a lot of different concerns for people with CF when they seek care outside of the CF team. A participant said, well, I have a firm belief that there must be gynecologists connected to CF teams, and there are not mostly. I very strongly think that what the CF team should do is say, we have a gynecologist who deals with people with CF. Not necessarily exclusively, but we have somebody who has seen these issues lots of times, and they can talk to you about it. Theme 5, highly effective urinary incontinence treatment options with low time commitment along with easily accessible resources are desired. Participants were interested in physical therapy via pre-recorded or live video, like Zoom. They prioritize treatments that are effective, non-invasive, and cost-effective. And there was an interest in preventative treatments, and many wish that they had started treating urinary incontinence early in their lives. The statistic that was shared before, that most people, it takes 6 years for them to seek care for this, is just shameful. One person said, at the stage of my life right now, I'm technically disabled because of my lung function, so I don't go to work. For me, a weekly therapy would not be terribly difficult to accommodate. If I were working, I might say something else. Perhaps if there was something like an online class for it. I don't know if that's a viable thing, but that could be a lot more doable. So the second part of this is how do we treat urinary incontinence and CF? And we heard a wonderful presentation about what physical therapists can do in this situation. I think this was touched on as well, and part of Dr. Bradley's study is a feasibility trial to evaluate non-surgical management options for urinary incontinence among females with CF. So this is occurring at 2 US CF centers. It's a randomized controlled trial of a disposable urethral support device, or the Impreza, an absorbent product, or PT with pelvic floor muscle training. They're randomized 1:1:1, and it's comparing tolerability and symptom relief among about 30 participants. The hypothesis is that all three of these are feasible and tolerable. So I'm going to go into what these are a little bit. This is the Impreza, or the disposable urethral support device. You saw a picture of this before and how it's inserted. It doesn't absorb, catch, or hold urine, but it gently presses against and supports the urethra. So it lifts it and may help stop the flow of urine that may otherwise leak out when you sneeze, cough, laugh, or exercise. It can be worn for 12 hours at a time, day or night. It shouldn't be worn during the menstrual cycle. And then after 12 hours of use, it should be removed and thrown away. So this is not reusable. You know, when I saw this as a pulmonologist, I was like, is this a pessary? This is what I remember learning about. Megan said no, but kind of. It's less rigid, and it's intended for a shorter duration of use, and it's not reusable. So participants in the study who are randomized to this arm receive a 1-week supply of the device, and then they're asked to complete a daily bladder diary for a total of 7 days. The second arm is the Speaks reusable underwear. This is the absorbent product. You can see these come in a variety of styles. You can buy them on Amazon. But we provide 2 pairs of Speaks underwear, 2 subjects, and they complete a similar symptom diary for 7 days. When I look at these, I really am concerned as to how much urine these can possibly hold. So you can see on the chart here that this holds about 2 pads worth of urine, or about 8 teaspoons. You can see they basically broke it down into how much can be held in these. And then this style can, for the light flow, can hold 1 pad worth or 3 teaspoons. And then I'm not going to belabor this. You guys heard all about this in a much better way than I just showed you. But this is 2 visits 1 week apart of a standardized pelvic floor exercise intervention. I'll talk a little bit about results and what we're really seeing with these folks in a little bit. The hope was initially when we conceptualized the study, this would be done in person. But I think with COVID and with everything that was going on and what we heard from the interviews, we've really moved to doing this either in person or remotely via video session. And I'll talk about that in a second. So how it's going. So only 5 folks have been enrolled thus far, so I don't have robust data for you, but I can tell you where we're at. We've had 2 randomized to Impreza, 1 to Speaks, and 2 to PT. At baseline, all had about 3 days of urinary incontinence-related symptoms per week. And when we asked them kind of our main outcomes, we found the following. So I think that it's so early to tell, but many people benefited from the treatment, especially on the PT arm and for Speaks. And there was much willingness to continue treatment, especially within the PT arm. Because people could be randomized to something they really didn't want to do, all participants elected to cross over and actually try another non-surgical management option after randomization. So, for instance, if they were randomized to Speaks underwear and they really wanted PT, after that period, they were allowed to cross over, and we're still gathering data on them. I'm just going to read. I had the ability to talk last week with the PT who's directly seeing these patients. She's seen 3 patients so far, so 2 that were randomized to PT and then 1 that crossed over. And she reiterated literally everything that you said. And I think that this is what struck me, because I believe maybe not PTs don't have this misconception, but I think a lot of people within the CF care community think, oh, their muscles are weak. It's exactly what that woman said in the quote, my muscles are weak. But really what our PT shared and what you shared is they actually have strong pelvic floor muscles, even too tight. So this idea, she reiterated lengthening before strengthening, and they all benefited from that so far. They all benefited from verbal cues regarding pelvic muscle floor isolation and strength and range of motion. They also all benefited from urge suppression training, and all of them were experiencing dyspareunia or pain with penile and vaginal sex, and that was really helped by PT, either 2-digit vaginal insertion or the use of the intimate rose wand to really help people relax their tightened pelvic floor. They were not aware of how they were holding their pelvic floor in constant contraction. And really, this really reiterates that this can lead to pain, weakness, difficulty with bladder and bowel emptying, and the feeling that one needs to void even if the bladder is not full. So I think it's important for us as providers across disciplines, if we're seeing somebody who's sitting in front of us who's suffering from a lot of constipation, this needs to go into our differential, in addition to all the CFGI things, to really think about, well, what's going on with their pelvic floor? And if we do pelvic floor muscle training, is that something that we can implement and try to help with that symptom? And also can help with urinary leakage, and then certainly this pain with vaginal sex. And after completion of the therapy, the 3 patients that have gone through so far had really remarkable results in regards to that aspect of their symptoms. Okay. So I think that when we got these interview data, and even before, everybody was a little bit like, oh, should we still do this study? Is urinary incontinence going to go away? And I think the answer is no, but I think it's going to change. You've seen this 3 times already, if not more, this conference. So many people are getting pregnant. And I think that this is a very different face of cystic fibrosis as we go forward. And it's not just people who are deciding to become pregnant, it's people in general who are aging, who are reaching reproductive transitions in their lives, including menopause. So I think a lot of questions remain. With more adults with CF and widespread use of modulator therapies, what the prevalence and timing of urinary incontinence is really uncertain, so we need to look at it. There's more pregnancies, so there's going to be more of kind of parity-associated urinary incontinence. The population is aging, so there's going to be more variety in the etiologies and types of urinary incontinence that we're going to see. How do we screen for this? Who do we screen for this? And what is the best treatment for urinary incontinence among those with CF? And I hate to leave any presentation with just a bunch of questions on the screen, but I think that my colleagues that went before me really gave you the tools that you can use to help your patients now as we build this research. I'm going to end on a very important message. For the safety of our presenters and attendees, I urge the Cystic Fibrosis Foundation to commit to ensuring that future meetings are held in locations where elected leaders understand the importance of reproductive freedom, gender-affirming care, and the sanctity of the physician-patient relationship. And with that, I'll say thank you, especially to all these people on the screen. Thanks so much.
All right, I think that is the 3 that we have today. So we have some questions. I'm not sure if all 3 of you guys want to come up, and whoever feels the most willing and can answer those questions.
Yes.
So our first question is from Michaela. Michaela, what guided your exercise prescription sets and reps through each trimester? How did you establish that?
So this is based on, I gave it for an individual patient and then kind of broadened it. I said I wanted to do, because my patients were like, I can do 4 exercises a day. That's what I could do. So I really wanted her to do a lower body strengthening, an upper body weight bearing, and then a posterior external or extensor strengthening. So,
Okay.
yeah. And then I educate my patients higher weight in the beginning, and if they need to back off, you can do higher repetitions and lower the weight as the trimesters progress.
Thank you.
Yeah.
Next question. What are your typical ways of instructing or exercises for lengthening of the pelvic floor muscles? I'll be able to address that question.
Great.
So the first thing we do, of course, in physical therapy is we do a comprehensive musculoskeletal exam. The second thing I do is I do a postural exam, look at the patient's posture, and at that same treatment session, and it's a long one, I use biofeedback. I've been very lucky at Boston Children's Hospital. I have a lot of support, not only from my pulmonologist and the CF team, but also from the Department of Urology. I was donated, the Department of Neurology donated 2 very highly effective biofeedback systems, and we do biofeedback sessions, and the first one is kind of use it as a tool, not as a total diagnostic, but one as a tool in my toolbox and a factor that helps drive my plan of care. So what I do is I do my assessment, I evaluate, and then it is a very patient-specific, my plan of care. I start off, of course, in hook line with diaphragmatic breathing exercises. I don't start off with Kegels because, as you know, if you're dealing with a shortened muscle or a tight musculature, it's going to do nothing. I do a lot of yoga, a lot of breathing. I also work on lateral costal expansion, which is huge with the diaphragmatic breathing. And I start with simple yoga positions. I start with the butterfly, the flower. I look at the hamstring length also in the patient. A lot of my patients have really tight hamstrings. I do the 90-90 test, and if I have over 30 degrees of lag or shortening, I start up with legs against the wall. Simple things, and usually it all depends. It's patient dependent. And also with the younger children is, am I getting that buyback from home? Is home working with me to help these kids? So some children or young adults, because I do see young adults, I'd say 3 to 4 sessions or maybe more until I really see that they can relax. And a lot of these kids nowadays that come in, because of the age of technology, I see a lot of rounded shoulders, forward head, because of the devices, shortened pectoralis minor muscles. So I have a lot of work to do. So that's what drives my plan of care with those patients. Kathy, you want to read that? Next. With the Impreza.
Let's see, pathophysiology. How do you explain how tight pelvic floor muscles are causing stress incontinence?
Yes, that is a lot of education. A lot of education. I use visuals. I talk to them about it. And then we also have at Boston Children's Hospital Avoiding Improvement Program. And they also teach strategies. And we work hand in hand with the VIP program to educate. We have specialized bathrooms that have squatty potties in them, bladder diaries, hydration's huge, and of course, the home exercise program. That's how we address that. And we talk about different types. Like I'll ask, when you're running or when you're coughing, do you leak? That's the big thing. Or how wet for the kids? You have to make it in language that they can understand. But then again, anatomically, we speak in anatomically correct terms in the clinic. So that's just basically until I get an understanding, and I review a lot every session. The kids come in, I review it just to reinforce it.
Okay. I think the next one's also for Michaela. How long should patients do lengthening exercises before transitioning to strengthening?
That's a great question.
Yes, patient specific. All of the factors, and then every week I'm, as a PT, your patients. When they come in, you have your guiding questions. You ask about the HEP, which sometimes is, oh, well, we were busy and we didn't get to do it, but. And reassessment. I'm always, and I kind of also use, after a while of treating pelvic floor, little tricks to see how tight they are. Like, oh, come do cobra pose. Let's see how you are. So that's how I do it. Very patient specific. Everything's patient specific. And as we know, some patients progress faster than others. So it is not a race, it's a journey.
Okay. Let's see. With the Impreza, is there a concern about the impact on vaginal health or flora and/or yeast infections, especially if used chronically? Sorry.
I don't know. I'm looking at my research. Olivia's here, my research coordinator, and she's pointing at herself, being like, "That was my question." Thanks. That's a great question. So we should definitely look at that. I think it's really interesting because the driver of yeast infections in people with CF is antibiotics. And I think as we're seeing more widespread use of highly effective modulators, this plummeting of pulmonary exacerbations. I don't know what's going on with the prevalence and incidence of yeast infections, so I think it might be a waning concern, but an important one if this is what we ultimately see out of this feasibility trial and a subsequent efficacy trial. This is the way we want to go. I think we want to really make sure that that's not happening. But I would assume in the general population, that's been considered and deemed not a concern. With this being kind of widespread use, but I don't know that data. It's a great question.
Okay. Yeah.
There's a couple ways of extracting
I think that's. So there's another question. What are your typical ways of instructing or exercises for lengthening the pelvic floor muscles? A lot of yoga, a lot of stretches. And then of course you're gonna evaluate and you're gonna see what muscles are tight. And from there, you pick the stretches that they need. And with children, I do a lot of play where I incorporate a lot of stretching. When we do the bear walk, I do obstacle courses, scooter obstacle courses, scavenger hunts. That's how I do it with the kids. And with the young adults and adults, more formally, just the stretching. But I get on the mat and I do everything I teach, I do with my patients. So that's how I do it. And of course, handouts, MedBridge, HEP to go. And sometimes even I'll have some parents video the exercises I'm doing with their children so they can replay them at home. And form is huge because if you don't teach proper form, you're setting someone up for injury. So pictures, videos, MedBridge, HEP to go, all of those things I teach. And a lot of reinforcement. I'll do a review at the start of every session. Let's review your exercises. Show me how to do this. And of course, with the kids, I have stickers, water bottles. You did a great job. Or, well, I have a water bottle for you, but I think maybe next time when you show me that you can really do these exercises the way you should. So that's how I do that. That's a great question. Is this one? Yeah. So here's another one. Are pregnant women with cystic fibrosis developing gestational diabetes more so than women without?
We're gonna find out. So I think that this has been announced a couple times during the meeting, and you all may know already, but the Mayflower study, or the maternal fetal outcome study among women with CF in the age of highly effective modulators is ongoing. They've enrolled 100 women thus far across 40 US CF centers, and one big arm and sub-study within that is around diabetes. Raksha Jain, Jennifer Taylor-Kauser, and then Melissa Putman are the PIs of that. So we're looking at it, and then hopefully there'll be data, not imminently, but soon, to really help us understand what's going on. But that's a great question. I think one we've had for a long time. And I think looking historically at it is challenging because the data has not been collected rigorously. And it's also challenging because that is a different era of CF. So now that we've got 90% of people on these highly effective modulators, we really need to look now at both people on modulators and then people who are not on modulators to get a sense for all people with CF who become pregnant.
Thank you. That's all we have for questions today, but in the future, if you would like to hear anything more about pelvic health in subsequent CF conferences, please reach out to our PT facilitators. We are happy. This was a wonderful experience for all of us. We all came together and shared what we're passionate about and what we love to do. So please reach out. Thank you for your excellent questions today and for attending. And hope you have a wonderful conference. Yes, Matt?
The conference surveys that will come out in a couple of weeks.
Yes.
Put them on there as well.
Put them on there because we're looking for topics and we are more than happy to expand on any topics as, multidisciplinary. I think this turned out to be a wonderful lecture this morning, and thank you to everyone. We've been working together for almost a year. Yeah, and it's been a wonderful journey, and I've had the honor and the pleasure of working with some beautiful people. Thank you so much.
Thank you
for attending. Stay up for the next